Welcome to our fourth webinar of the Evaluate Digital Health webinar series. So for those of you who don't know me, my name's Brett. I am an NHS navigator on the DigitalHealth.London Accelerator program, where we identify and support 20 high potential digital health innovators every year to achieve spread and adoption across the NHS and care systems. I'm going to be one of your co-hosts today with Katya. And this session today is about what digital health evidence do commissioners and clinicians want to see? Now, I'm sure literally every SME whose solution is bought by commissioners has asked this question at some point. It's a question that we hear a lot on the DigitalHealth.London program, and yet sometimes the answer is never quite clear or simple. And I know this because I was a digital health commissioner for the Sussex CCGs. I'm actually a nurse by background, but worked on a number of digital projects in Sussex. The main one was around procuring and implementing virtual consultation solutions for GP practices in the Sussex area. So while SMEs and commissioners do have guidelines in terms of what evidence we should expect, the ultimate decision does lean on the business case and the local governing board that makes those decisions at CCGs and trusts. So at the board meetings, senior NHS managers often scrutinise the evidence in our business cases, and sometimes what they're looking for can vary depending on the decision maker and their background and experience. But there is still hope for SMEs. If you can provide the commissioner or clinician with the evidence to demonstrate the efficacy of your solution in a clear and suitable format, we'll seriously love you, because it does make our job so much easier when we want a solution in place for the NHS and social care systems. So that's what we're here to talk about today. What are commissioners and clinicians looking for in terms of evidence? We have a really fantastic group of panelists for today's session. So I'm going to hand over to some of them to tell you a little bit about their current role, their organization, their background, and experience in the commissioning world. And I'd like to start with Rishi Dasgupta, the CEO at the Health Innovation Network. Rishi, take it away.
Hi, I'm Rishi Dasgupta. I'm the Chief Executive at Health Innovation Network. We're an academic health science network focused on spread and adoption of innovations. And prior to this role, I've worked at acute trusts as an innovation and technology officer. So, Brett, back to you.
Brilliant. Thanks, Rishi. And I'll hand over to Vicky as well, who works with the South West London Health and Care Partnership.
Hi, thanks very much, Brett. Yeah, my name is Vicky Nelson. I'm an Associate Director of Transformation, and my portfolio is the Ageing Well theme, so enhanced health in care homes, anticipatory care, including end-of-life care and community integration. And I work for South West London CCG, which is with Health and Care Partnership. And I've been involved with, particularly around care homes, some of the digital work, so running sort of proof of concept pilots, so working with some of the software providers, and more recently we've undertaken a large procurement process around remote monitoring and providers for the care homes project.
Fantastic. Thanks, Vicky, and it's great to see another fellow Australian on the panel. Rob Sweeney, we'll take it over to you. Rob is the COO at Greenwich Health.
Hi there, thanks for letting me join today. My name is Robert Sweeney, I'm the CEO at Greenwich Health with the GP Federation for the Greenwich Borough. I'm going to hopefully bring a bit of a perspective from a healthcare provider side of things. We've commissioned a lot of digital solutions in a lot of what we do. I was also part of the NHS Digital Pioneer Fellowship as well, so I've got quite a background in digital.
Fantastic. Thanks, Rob. And Ben Wadness is a consultant physio at St George's Hospital Trust. Ben.
Thanks, Brett. Hi, yeah, I'm Ben. As Brett said, I'm consultant physio. I'm also involved in implementing some digital solutions and some research around some of those digital solutions. So hopefully I can give a bit of perspective from a service provider, a clinical lead, and perhaps add in the research elements as well.
Brilliant. Thanks, Ben. Well, fantastic. That is our panel for today. I think we should get started on the questions. And our very first one that I want to ask the panelists, if it's possible to do this in one, maximum 2 sentences, is what do you understand as evidence when talking about digital health companies? Rob, we'll start with you.
So I guess from my perspective, looking at it from a provider perspective, it's always about looking at, I guess, the suitability and functionality of what's being provided, looking at the usability of it, and also getting an insight into the kind of credibility of the organisation as well.
Brilliant. Thanks, Rob. Vicky?
Yeah, I think building on that is definitely understanding how it works. Is it going to be suitable for the purpose we want? And thinking around all of the elements that support that. So thinking around the IG, the IT infrastructure. And what's really useful too is almost knowing other organisations they've worked with, so we can also drill down and understand how they're successful or what the challenges were within those other projects.
Absolutely. Thanks, Vicky. Rishi?
I would have it in two categories, really. There's sort of a set of stuff around testimonials, and then for most companies, we look at sort of small scale studies and focused on really three things. So the efficacy of the product as a whole, how customers and users like it, and also the implementability, and that last one is really important, actually. So how easy is it to put in place?
Absolutely. Thanks, Rishi. Ben?
Very similar to the others. I suppose we just frame it in a slightly different way. I tend to almost treat it like we would do applicants to a job, where we have basic essential requirements such as CE marking, IG sign-off, etc. Additional but essential requirements such as the DTAC or the NICE DHT evidence standards framework evaluation. And then there's the additional beneficial stuff, the real life data evidence, efficacy, economic evaluations, and then not forgetting the qualitative stuff, the acceptability, some consideration of digital inclusion, all those types of things.
Absolutely. And something you touched upon there, which I think is so important, and we'll touch upon it later, is just digital inclusion and really incorporating evidence around making sure we consider vulnerable groups. And as Rishi said, make sure that the evidence we have is translated into implementation and not just during that procurement phase as well. So really important points. I feel like we've set the scene a little bit, what evidence is. The next question I'd like to ask, I think, is one that we're all thinking about, but what would our panelists like to see from digital health companies in terms of evidence when SMEs present it to you? Is there any particular format of presentation, any publication type, or any research methodology that you prefer or you found works really well? I'm very curious to ask. Ben, I'm curious to start with you just on what you would like to see in terms of evidence at St. George's.
So for me, it's presenting it in a really simple form. So what the problem is, so the context and the scale, the solution that's going to solve the problem, and that needs to be in plain English. And often we invite our clinicians to those types of meetings, so it's not just people with an IT kind of understanding and head on. And then really key to that is a demonstration of the application, so people understand how it will work in real life situations. And then lastly, the evidence presentation. So, and going into the design and the methods is quite helpful before the results are shown, I guess.
Absolutely. I think you raised a really good point, especially around making sure that the language is really plain and understandable, because coming from a clinical background, you want to you understand the lingo in that field, but when it comes from maybe a digital tech perspective, sometimes that's a totally different world to what we're used to working on the ground on the wards or in the hospitals. So very good point. Rishi, I saw you nodding along. I was curious, did you have another point as well?
I think it's really helpful. I think Ben's spot on, and I think the other thing for SMEs to particularly to focus on is that decisions are often made in collaboration with a number of people in either the system or in a particular hospital. And so having things that are in multiple formats that you can put in front of different people is really helpful. So, having the one pager that summarizes what's there and the backup technical detail that I can hand to an IT person is really important. The other thing I'd say in terms of, you mentioned format and sort of the level of evidence, we see a lot of different levels of rigor and robustness to the evidence, and also size and scale of studies. And I think I always look for clarity and openness in that sort of communication. So are the claims that are made kind of reasonable and robust for the level of evidence that's there? And you know, if those two things don't match up, then I'll probably have a closer look at what's there than otherwise.
Absolutely. Yeah, thank you, Rishi. And Vicky, I'm curious to ask, in Southwest London, or in your work with care homes, is there any particular evidence that you're looking for in any particular format or publication type?
Yeah, I think, as Ben said, you know, there's this simple format, you know, drawing on what the speakers have said, the simple format, that it's plain, it's understandable, that you do kind of grasp that you're going to have a wide range of people who will be participating in the procurement, and trying to tailor or adapt or try to meet that wide range. And particularly, you know, we know within the care homes there's different sorts of levels of sort of literacy and understanding some of the technical issues. I think there's also just trying to really kind of having done that homework about the drilling down into how it meets up to what the clinical issues are that we're trying to address. And you know, that might mean having kind of subject matter experts who are helping on from their perspective to help shape some of that evidence and show how it meets some of these clinical standards, and also that they understand, I think, some of the challenges that we face and how that could be overcome. So some of the things, particularly around IG, something, you know, a big issue we face in care homes, and where we have seen, you know, kind of this mismatch. Something looks absolutely fantastic, but actually it requires quite a high level of IG standard for the care home. So it's a long process to get it implemented. So I think that kind of understanding that and having addressed that and considering different options is really helpful.
Really good point, actually, because often we would see bids coming in with really exceptional products, and they would highlight all the really brand spanking new things that they could do and all the great benefits that it can provide. But sometimes the basics were not as thorough and comprehensive. So it's really important to get those essentials such as IG extremely thorough in those applications as well in terms of evidence. So yeah, absolutely. Rob, did you have anything else to add as well?
Yeah, I mean, some of it echoes what's been said already, but I think the best way that I've found to think about this question is I mean, we had an event recently where we were looking for a digital health partner to support some of the services we provide, some of our practices, and there was a real clear company that shone above everyone else, and they gave a really clear demonstration of the solution. It was very hands-on. We could see how it worked, what the patient would experience. It was also very clear how the implementation would work, particularly coming at it from a provider perspective. Time is often very short. We need to see what kind of support is going to be given to implement the solution, and that needs to be backed up by evidence use cases. So where has it worked elsewhere? Trying to link that into what organisation you're going to with your product. But some really well-defined use cases showing real benefit and backed up by lots and lots of data, which really shows, and credible data, which really shows the success that could be provided by that solution.
Absolutely. I think that kind of leads nicely into a follow-up question, and I think we've all touched upon it slightly, but what type of evidence, if there is any, that would put one supplier in front of the other, especially when considering the evidence relevant to that innovation? So obviously not everyone needs to do an RCT, but sometimes evidence can be presented in a way that puts someone in front of the other person. So I'm curious to ask, does anyone, maybe Vicky, if you don't mind, we'll start with you. What type of evidence do you think would put one supplier over the other in Southwest London, for example?
Yeah, sure. And I think it's building on that really as you said, there's the essential, I think it's really nice how Ben described it as a job, applying for a job, that you've got your essential criteria that has to be met. But I think when a supplier really seems to have an understanding of that market that you're going to work with, that they have clinical, kind of knowledge and acumen that they can build into it, and that real understanding of how you can overcome some of those barriers and hurdles to implementation, that just shows that they have got that experience. They've kind of looked, really understand some of the problems that you might have to overcome, and to put that in place. Because what we don't want to be doing is buying a product that we just can't get off the ground and we can't get working, no matter how great it is. So if they've kind of foreseen some of those things, and almost, I think, an honesty about, yes, they have to be through the data security and protection toolkit, in terms of care homes. However, this kind of some sort of solutions to help that, or how that could be augmented. I think that really is really helpful. As I said, I've got sort of the limited with the long procurement, but we've done some work. But I think that's from my perspective.
Yeah, absolutely. I'm wondering, Rishi, did you have anything else to add? Do you have any ideas on what would put one supplier in front of the other?
Sure. So, being brutal about this, one of the best tests of whether or not something's going to work is, has it worked elsewhere? And so I always used to put whether or not there's a case study of this having been deployed in another site. So it kind of depends where you are in terms of stage of development. But if it's already working somewhere, then the case study and testimonials, that, because it contains efficacy data, testimonial data, and implementability data all together, are really valuable. And many of us have informal networks, and will check on whether or not things did pan out the way that they're presented in a case study. So again, that openness and honesty about what worked, what were the challenges to overcome, are really valuable. And you mentioned RCTs. I mean, RCTs are good because in pharma, because they contain both robustness and independence in the way that the work is done. And so I think that, again, having something which has had an independent eye and isn't just proprietary data presented to us in a way that we can check is really, really important. And that is a tough ask, I know, but that is sort of what we'd look for.
Absolutely. And I think you've both, you and Vicky, touched upon just the importance of really having a very robust understanding of that clinical pathway that you're trying to influence, and making sure that you can see, especially that for me always put someone in front of the other, was knowing that they had a really good understanding of the challenges, but also that clinical pathway that clinicians and others would engage with as part of that solution, and seeing that they really thoroughly thought about how that solution might impact that pathway was really always positive. Rob, would you say the same applies as well in the primary care world? And is anything that would put others in front of other suppliers in front of the other?
Absolutely, and from the kind of bits and pieces I've done in that area already, it's often fine lines that make the difference. And I think often, like Vicky said, people are on the framework, so they've got that evidence and accreditation behind them. It often is, and I know we've mentioned it a few times, but what Ben said is very true. It's often about how credible you feel that organisation is, how open they are, how much do I feel I can work with them, and having use cases behind that to show where it has worked, and maybe sometimes it's good to be given a contact or two from who may have worked with them before, so you can really go beyond just what they're presenting, and have a separate conversation just to see just how successful it's been.
Absolutely. Those case study scenarios of previous successes sounds like it would absolutely be essential in that evidence stage. Ben, is similar experience for you? Anything else to add?
The only thing to add really is kind of touching on Rishi's point about having the solution implemented locally or in another place. We all hate to have to do something, and there's this obsession with doing a pilot, even though we've got evidence even from our neighbours that they're already implementing something. So I think that's really valuable. But I guess with that, I'm always interested in some more kind of thought or qualitative work from the company about how those populations are the same. Because if you can bring that to the table and say, actually, we've looked at the population where you are, and some of this applies, but there's some new demographics in here that we've got to consider. Therefore, we're going to do this, and we're thinking of doing this. All those types of things, they're really interesting. And I suppose going back to the whole RCT thing, realistically, that not many companies are at that stage, are they? So I think showing, alongside some of that qualitative stuff we've just spoken about, some sort of quantitative data-driven stuff about the system impact is beneficial. And then longer term, if we do go down the kind of route of formal trials, I think we've probably got to look at not just RCTs, but more of a mixed methods approach, because those two things side by side and looking at the patient perspective and the acceptability of these types of solutions, interventions is really valuable, and we shouldn't miss that.
Absolutely. Rishi, I see you have your hand up. Did you want to add something?
Just to build on Ben's point, I think one thing for early stage companies to think about is how a pilot or a first implementation can build the evidence base for further rollout, and alongside the rollout, what data should be captured and who should independently be looking at it. So that can be universities, it can be AHSNs, it can be others who are doing that evaluation in parallel, so that at the end of it, the case study evidence is generated.
Absolutely. Really good points. Thank you. And I think, again, it kind of links in with our next question. And we've touched upon this point a couple of times already, but I wanted to ask the panel, from your experience, could you give us an example of when evidence provided by a supplier during the procurement stage matched what they said the product could do when it came to the implementation stage on the ground? And if you have an example of when it did work or when it didn't work, or when that evidence did not match during the implementation phase, that would be really helpful as well. I'm curious to start actually with Rishi, because I know you've had a lot of experience in your past roles at Royal Brompton and UCL NHS Trust. Do you have any examples of, appreciating that it might need to be anonymous?
Hard to do this anonymously. What I would say in general is that, by and large, directionally, the evidence kind of always matched what we did in terms of reality. I've not had experiences of things that genuinely didn't do what they said on the tin. And I think that's probably many of my colleagues' experiences. But in reality, when you put these things on the ground, the implementation affects the way that they work in many cases. And so I've had lots of examples where directionally they work, but either it takes longer to get to the benefits, or I think the thing that I've seen most is we put in an RTLS system at one of my hospitals that was supposed to improve efficiency. I think it did improve efficiency, but we radically underestimated how much time and effort it would take to roll it out on the ground, to get everyone using the new ways of working, and the time it would take to get all those benefits. So, the evidence base that we were given suggested you would get it pretty much overnight, and in reality, it took more like 6 months to a year. So, I think that's what we've seen.
Absolutely. And Vicky, is this similar to your experience in South West London as well?
Yeah, I was just thinking through this, and I think there's, and again, I'm trying to remain anonymous, but some of the sort of technical pieces, and it's been around ID with care homes where there was sort of a lack of, something that was said, well, while you're working towards the DSPT, they can start entering the information onto this, and it's not shared with the NHS. And we thought, oh, that's great, because we can do these things simultaneously. But then in actuality, the IG lead said, yes, but actually by entering it onto and going onto the cloud, that is data sharing. So So we're kind of stuck having to get them through the DSBT before we can move. We can't do this simultaneous. I think on so it's kind of that sort of real, you know, enough sort of level of understanding of what the IG rules are that we have to deal with, because that is slowing our project down. But I think on the counter side, and this was a company we'd worked with, a software supplier, because you know, don't want to get myself in hot water saying the wrong thing, but, you know, what we do see with some of the NHS sort of patient record systems is a real reluctance for sort of sharing and permitting and facilitating integration of care records, and barriers, both sort of IT delays and financially, you know, to that to happen. And when we started working with care homes and wanting to share information between a software provider in a care home and with the NHS, what we didn't want was to be creating a monopoly where there was one software provider who could do that, and all the care homes would go to them, because there are different reasons why different software is being used. So what was really, really great about working with this provider was they said, we totally understand this, and what we commit to doing is setting up an alliance, you know, to share what we learn. So we share our kind of methodology, the process we have to go through, the technical process, the IT steps, with other providers, and they have followed through on that. So we do have kind of, we've only got 3 at this stage who are using this and doing it, but they do have other people who are members of their association that they have. I think, yeah, they're kind of two examples. And also I think a really pivotal thing that I did want to say at some point today is just how important it is that people understand we need to have that ability to integrate and to share and to not have huge financial barriers or complexity barriers for other providers to be able to integrate. That's a really key and important piece.
Absolutely. Key points on interoperability there. Thanks, Vicky. Yeah. Rob or Ben, did you have anything else to add? I'm curious about your experiences. Ben, we can start with you if you have any around evidence matching what you expected it to do from procurement to implementation.
So I suppose intriguingly, everything we've procured has only ever really had the basic essential stuff that we spoke about earlier, and that you check before you procure them anyway. Just, I think, again, going back to the fact that a lot of these SMEs companies haven't got to that stage yet, but they did. So as an example, we're working with a company called Get You Better. They had all the basic requirements. They had a roadmap of how they're going to meet the other things. And that has proved fruitful, and they've continued to kind of work on all of those things. And since we've been working with them, they've done digital health technology evaluation as an example. And we're going into some research with them. So all of those things have come about, which is quite good. I suppose the other thing to say about them as a company, and this isn't necessarily evidence, but they certainly kind of spoke a good, they talked a good game around working with local stakeholders and delivering a solution across a whole pathway. So Get You Better, if you don't know, is a musculoskeletal self-management solution. I won't go into any more detail, but as I said, they talked a good game, and everything they promised they delivered, so that was really good. And we had a good feeling, and that's continued, that they had a good ethical stance as a company, and they were quite altruistic in their vision. So that was a nice thing to see, and it's continued. And I don't think we should forget about those really important traits. So I think we did at one point ask them, you know, what is your roadmap as a company? Because we wanted to find out, you know, are they there to provide a solution that can be scaled for the greater good, or are they there to build something that they can sell off commercially and go to America with? But they seem to be very NHS centric. It was set up by NHS clinicians, so we had a good feeling. Unfortunately, I'm sure for others that hasn't been so positive. Fortunately, that kind of all aligned and came true for us.
Thanks, Ben. That's a really great real world scenario, actually, on how some of the evidence has matched what they what happened in implementation. And I think that's really fantastic. Get You Better is actually on the cohort of DigitalHealth.London. So it's great to hear that things have been progressing really smoothly. And I love that there was a lot of transparency in what they could provide and what they were going to provide in the future. And they really met those targets. So that's really great to see. Rob, did you have an example or anything else to add as well?
Yeah, I mean, I've got a good example and a bad example. I mean, we had a really good experience with a digital health company when looking at procuring for a partner in smoking cessation services across the borough. So that it was an organisation at the kind of more mature end of the spectrum. They had lots of data, lots of data that wasn't just proprietary, but it's sort of data out which is out there backed up by science. And they promised a lot in terms of results, but they promised a lot in terms of how they would implement and drive implementation. And we ended up with a really good collaborative arrangement with them. They delivered everything that they said, everything they presented before us, and we had some fantastic results in what is a really difficult population to make change to. So, and we ended up one of the kind of areas that we looked at together from the start was how we could maybe put a case together as to how we worked in partnership to build something for the future, and we did that really successfully. We had another experience with another digital health company, and that was at the start of the pandemic last year in April. We were tasked by our local CCG to deliver a hot site, so practice could send any suspected COVID patients to. And we wanted to use a kind of virtual consultation within the same building way of making sure that we weren't having too many contacts with the patient, our staff. And while it helped from a video consultation perspective, it didn't really hit what they provided to us in terms of remote monitoring. And so it kind of was quite a tricky implementation. We had to do a lot ourselves, a lot of problem solving ourselves. It was a very short time span, to be fair, but we kind of got the feeling at the end that what we were promised to start with and what was shown to us in terms of evidence didn't really match what was provided. And there wasn't that collaboration, which I think is so important in making sure you have a good, smooth implementation which fits the purpose that you're trying to address.
Absolutely. And you touched on a really strong point, I think, about the collaboration and the importance of that partnership between the commissioner or clinician and the SME as well. We should never really, it's easy to sometimes lead them to do what they need to do, but establishing that relationship and regular contact with them is always really, really helpful in the early stages. Thanks. I think some really good examples have come out of that question. So thank you. I wanted to move on to another question, which I think is really, really important. Something that the NHS is still grappling with and becoming better at. But I wanted to ask exactly what do our panelists ask or expect to see from suppliers in terms of evidence showing impact on the vulnerable groups? So I'm very curious, Vicky, I know with your work in Southwest London, I was curious to ask what evidence you expected from suppliers in terms of that impact on vulnerable groups with some of your work in care homes and other projects.
Yeah, and I think building on what we have talked about, isn't it, is some of the case studies or the examples that they have where it's been implemented in other areas is probably what we would be looking at. And I think an understanding of what some of the issues might be. So, you know, I'm aware when we're working with care home staff, there are issues around sort of literacy as well as language. So, you know, how would they propose to address some of those challenges, and digital maturity as well? You know, how would they propose to address some of those, you know, those points and those challenges?
Okay. Really good point. Thank you. And Rob, as well, what were your thoughts? What do you expect to see in terms of impact on vulnerable groups?
Yeah, I echo what Vicky said. Really, I think it's all about where has it worked elsewhere, and how have you managed to address those inequalities elsewhere. We have quite opposite ends of the spectrum in our borough, and every time we implement something, we always have to have this at the forefront of what we do. Obviously there is a misconception that there is a lot of the population that can't access digital solutions, but I think if you package them in the right way and if you wrap them in with other things that that make things accessible, and have evidence of that actually happening elsewhere. I think you can get over those hurdles, but I agree with Vicky. I think it's all about use cases and where it's worked elsewhere and before, with good data to show where sort of inequalities have been addressed using a solution.
Absolutely. Rishi, did you have anything else to add in terms of what evidence you would expect to see?
I might just flag up the way that we do this on our end from the NHS side, and it may not be obvious to SMEs that we have to fill in a equalities impact assessment for pretty much anything that we would be putting in as a new scheme. And the aim isn't always that we have to have no change to the equalities from a new technology. And I'm actually quite passionate that if we put in a new technology, it might help some people first and then spread to others. And also it might create capacity in the system that allows us to provide different care, different and better services to the people who are left, who are potentially excluded by a new technology. So it isn't that it has to be perfect, but it does have to be understood. And we have to be able to do that equalities impact assessment. So capturing data on, which users are benefiting most from a digital intervention or engaging best with it is really important in pilots and in rollouts. And I think what I think is most compelling for me is when people have a real clarity of understanding of the issues, both with protected characteristics and with things like digital exclusion, as we go through this.
Really good point, actually. And I know working in Sussex, equality and health and equality impacts assessments were just such a core part of what we did. And sometimes, often when we received evidence from suppliers in Sussex, not always was there that consideration of how their product might impact on health inequalities. Sometimes it would be great, it would really support certain communities, but sometimes that maybe wasn't emphasized. And I think that's a really big part of what we do now. So I agree, it's certainly very, very essential. Ben, did you have anything else to add on your work as a physio at St. George's?
Not really. I think Rishi's point is really important, though, about it's not always about delivering something better digitally. It's about creating capacity within the system, and the work we're doing with self-management is a good example of that, because actually it's about providing a tool for people to use if they can. And so yes, if you're digitally enabled and you can manage your condition, then you can. And what that does, it creates capacity for the vulnerable groups to actually be seen within the system elsewhere. And actually you could argue that they're getting better care because they're being seen by a clinician quicker. So they're not included within the digital thing, but they are still getting good care because of the digital solution, if that makes sense.
Absolutely. There's so many indirect benefits of solutions freeing up time for clinicians and admin staff, where they can then redirect that time to those who may not benefit directly from that solution. So there's a lot of indirect benefits from digital health solutions as well. So I think really good points. I'd love to finalize this round of questions with 1 point from each of our panelists. And I want everyone to, I want to ask, do you have any parting top tips for digital health companies generating evidence? What would be your #1 tip in one sentence? Ben, we'll start with you because you've just went. If you could have it, if there is one.
Well, in one sentence is difficult, but what I would say is avoid the kind of the language that we often see outside of the healthcare world. So one of my pet hates is when people come in and they say they're going to disrupt the healthcare service and scene. We don't want disruption. We want things that are going to help. And so comparing yourself to Netflix or to a new AI tool that's kind of changed the way we think about banking is not necessarily helpful in the healthcare setting. So yeah, evidence that is robust and sensible, pragmatic, and is applicable to patients. And don't forget although some people don't like that word patients, you know, they are people with health conditions and problems. This isn't just about disrupting a system for you as a company to make money.
Absolutely. Thanks, Ben. Rob?
For me, it's all about understanding what the organisation is looking for, what their pain points are, and trying to target your evidence around what you think you can do to help and show real world examples of that. That would be my insight there.
Absolutely. Thanks, Rob. And Rishi?
I think that I will, I think just as the others have said, I think the key bit is that it addresses the pain point, but it also meets the hygiene factors on addressing all of those key bits around efficacy, implementability, financial benefits, and that there is something to address on each of those. And then critically, we're seeing more around the equalities impact assessment and digital exclusion. So kind of the best evidence does all of that.
Absolutely. Thanks, Rishi. And Vicky? Are you still with us, Vicky? No, that's okay. Well, I will just reiterate, as my top tip is to cover the basics. I think Vicky touched upon this before, really important, but there's so many products that do some really fantastic things, but if they don't cover the basics, we don't want to procure it. So that the evidence in terms of demonstrating that you cover the fundamentals is really key to any format of evidence that you provide to commissioners. So I think it's a really important point that was made before. So thank you so much. I think some SMEs have some really great things to take away from some of those answers. And I would love to hand over to Katia, who is going to talk a little bit more about, we'll pull out some of the questions out of the chat and we'll do a bit of a Q&A.
Fantastic. Thanks, Brett. Hi all, I'm Katia. For those who haven't met before, I head up the Digital Pioneer Fellowship delivered by DigitalHealth.London, and I'm also the Program Manager for the DigitalHealth.London Accelerator. I am going to, I've been keeping my eye on the chat. We likely won't be able to get through all of the questions, but I've tried to pull out the ones that seem to have the most amount of relevance to this webinar, but also people seem to say, yes, we really want to know the answer to that question. So the first question is around, interestingly, sustainability and kind of the net zero target that the NHS has in terms of sustainability. So this might not be relevant to all of the panelists, but would be interesting if anybody does have any experience with this or knows any things that are coming up that might be affecting the way that you procure or the way that you look at evidence from digital health companies. So naturally, some types of evidence do look at factors that affect healthcare, that are things like climate, if you think of respiratory patients, etc. But to date, almost no procurement accounts for such impacts. So the question is do the panel have any experience with presenting anything around climate or sustainability and the impact that might have on health? I'm not going to pick on anybody because I appreciate this is experience-based. Anybody willing to put up their hand? Rishi?
It's an important topic, and there isn't very long to go until our climate change goals for the NHS have to be met. So I expect it to go up the agenda, although to be clear about it, don't think it's as high on the agenda at the moment as it could be, and COVID has certainly meant that our eyes have turned more to a lot of things around safety at the moment. Where I've seen it really powerfully put is looking at digital outpatients and changes to outpatient models to result in fewer visits to central locations and travel, particularly in national centres actually. And I found that that's been quite powerful when converted into a tons of carbon metric for the travel time. And so I've seen it there, and I've seen it also in some of the sort of power management solutions that are available for buildings management in NHS. You know, we have a lot of buildings, many of them are quite old, they cost a lot to heat to the outrageously high temperatures that we tend to have healthcare institutions built heated to. So I've seen it in those two fields, but I'll be, you know, to be frank about it, I haven't seen it in many others yet.
Fantastic. Thanks, Rishi. A follow on to that question, but I think is relevant outside of purely the sustainability element of it, is when digital health companies are presenting evidence to you. We've spoken a lot about them presenting case studies of work they've done in other healthcare organizations, and really showing what they've achieved to date and being open and honest and transparent about what those challenges were and how they've learned from those. But an interesting question here was, does presenting theoretical papers help or hinder? So if you think of a product that presents, a broad academic paper on, does remote monitoring reduce costs? Does it save staff time, etc., that maybe isn't relevant to their specific product, but shows kind of a broad impact of remote monitoring. Thoughts on that? Does that help? Does that hinder? How far would you be willing to stretch that in terms of them using that as part of their discussion with you? Robert.
I think from my perspective, it could be useful in maybe a scene set, from a scene setting perspective. It would be quite useful to see how it theoretically fits into the environment. But I think it would help, but only in that regard. From my perspective, I think I'd be looking for more real kind of evidence that relates exactly to what we're looking at and what problem we're trying to solve.
Rishi.
Again, on the back end of this, all of us would be trying to put together a business case as to why we should, make an investment in a particular product. And I think against that, we have to put some assumptions about what we think the costs and benefits will be, some financial, some non-financial. And any sort of evidence is helpful. Academic papers, sort of broadly, are often helpful. But they get discounted a bit because if the jury's still out in terms of academia in general, then you can usually find papers which have quite broad ranges of what the outcomes are. And I know that in the past, some of the organizations I've been involved with have asked prominent academics to just provide a quick review of literature on things in order to be able to try and work out what those assumptions would be for some of the larger procurements. So useful, but not as useful as evidence from direct implementation.
Fantastic. Okay, so we're leaning more towards helping as opposed to hindering, but does need to be realistic and can't be in replace of anything regarding their own evidence in different organizations. Leading on from that question a little bit, we had a question around, let me find it quickly, around implementation and evidence from places outside of the UK. So you might have an organization that's very well established in a European country. They do have evidence showing that, but they don't have any evidence to showcase to you from a UK organization. Thoughts on that, how you feel that would change their pitch to you? Naturally, obviously, there's nothing they can actually do about that at that stage, but any advice in how they can wrap that up? Vicky or Ben, one of you.
Yeah, I do apologise. My laptop had crashed, so I was off screen for a few minutes. Yeah, I think what you would really want to see, because granted it can be successful and in one country, so there's obviously the option that it could be successful here. I think what you would really want to see is that the supplier has done their homework to understand what are the differences between those countries, between those systems, and kind of perceiving, how there might be some different challenges, or there might be some simpler solutions as well to the country that it has been successful in. So some of the clinical background, the clinical reasons for something working, that is almost more universal, but it's probably some of the kind of rules and regulations. I'm thinking like with things like care homes in this country, they're all independent providers. What does that give? Whereas another country, they might be provided by the state. So it's kind of understanding what the differences are and having shown that they've done that background, really.
Fantastic. Thanks, Vicky. Anything to add, Rishi?
I would add, I think there's a similar question in the chat around moving from primary care into secondary or tertiary care or between care settings. I think the key bit from my perspective is to try, just as Vicky was saying, to show what the applicability is. So some metrics of, what size of organizations are we talking about? What number of doctors, nurses, AHPs are involved in that kind of program? What scale of population is it working over? What was the adoption rate within a particular population? All those sorts of things make it easier for the people in our health systems comparing this to say, well, was the example from abroad a comparable example? And I think Vicky highlighted very helpfully, payment mechanisms and things in that are also part of it. So useful to think through.
Fantastic, thanks, Rishi. Yeah, that really does lead to the question around evidence from a different sector being used. Robert, I don't know if you've come across that in the primary care sector, if you've had evidence from suppliers that's maybe not from the primary care setting, but is a space that organization would like to grow into. So they've got evidence from secondary or tertiary care.
Sure. I don't think I've had any examples of that, but I mean, I think it's a similar response as from the question before. It's how you relate it and translate it to the different settings. And again, I come back to my response earlier on around looking at how you present yourself. I think you need to look at those pain points and how you can use the evidence that you've pulled together from whatever setting it is, and relate it into the situation, the problem you're trying to solve. I think there's a lot of data you can pull from a different setting, from a secondary care setting, which can be related into primary care. Like I said, it depends on the individual case, but it's just how you relate it, I think, and how you deal with a particular problem.
Fantastic, thanks, Robert. Right, we have time for one final question, and maybe a bit of a practical question. I see someone's just popped something in the chat. No, okay, not an additional question. So we will keen to kind of do a bit of a practical question in terms of the type of evidence that is presented to you versus the type of evidence that you would like to generate while under pilot or contract. So naturally, the evidence that presented from you might be from an organization that's slightly different. They might have looked at a slightly different part of the pathway. But thoughts on how often you're in a position where you've seen the evidence presented, but you really shape that evaluation of the product in your setting very differently. And your experience working with companies to do that. How has that experience been to really shape an evaluation? It's quite different to what they've done before. Any learnings from that, times when it's really worked? I can see some thinking faces. Ben, any thoughts from your side?
Well, I'm afraid I haven't worked with anyone who has come with a completely different product in a completely different context, and therefore we've had to rethink about how we evaluate it. And I guess that's what comes down to what we've been looking for in our product. So no major insights apart from, obviously you'd want to work with someone who shares your vision and values, and it's going to become apparent quite quickly if there's a difference. Now, I'm not saying that a difference in opinion shouldn't happen, because that's good. It's good to have, diversity in thinking as much as everything else. But obviously, if a company, like I was saying before, has a particular vision about where their company's going to go and what the product's going to do, and that differs, and that's going to come out quite quickly in terms of what you evaluate. So it's just a matter of kind of getting that sorted early before you procure them, I guess. That's the take-home message there.
Okay, so that would almost be part of the selection process. You would want someone, there would be that benefit of having done something very similar as part of the procurement process. Any other thoughts from the panel? Parting thoughts? Rishi?
I think we've focused a little today on sort of, particularly on SMEs, sort of having interactions with individual trusts or individual regions. it might be worth having a moment to think about sort of national spread and regional spread, and the way that AHSNs help with that. But what we're looking for at the point at which some innovations make it to the point where we're looking to do national spread, or spread in large programs across the region. And at that point, the evidence base that we would be looking for is, what is the efficacy and does it work? What is the impact on carers, and how on carers, patients, and their experience, alongside the cost-benefit analysis, the implementability analysis, and a set of technical requirements. And if the ambition is to get to that stage, then of course the first few implementations and pilots of it, ideally in different kinds of settings, different settings of care, urban and rural, to try and build that evidence base is quite important. And I have seen some companies that have been very tactical about it, and said, well, we've now got an urban implementation, we now have to chase the rural implementations to make sure that we can show that it works in both kinds of settings. And so the extent to which some of our participants today are in a position to think that far ahead is quite useful. But of course, we also have to be pragmatic about it sometimes.
That's fantastic. Thanks, Rishi. Right. That was an amazing discussion. Thank you so much to the panelists for joining us today, as well as all of those on the call. As a quick roundup, I managed to scribble down 8 takeaway points that I thought would be interesting. So the first one I think really key was plain English. It was definitely a takeaway in terms of when presenting your evidence. Being able to allow your commissioner to share that with as many people in their organization who can then understand that and give feedback is so important. Really addressing or showing how you're going to consider the implementation, being open and honest about challenges you've had in the past, type of support that your team is going to supply, etc. Focusing further than just staff using your product, but how that works with implementation, IG, etc. Showing use cases, really important. If you have them, really share as many as you can. And then leading on from that is having references. So being able to allow your commissioner to touch base with individuals who have used your product really gives them an opportunity to learn things from, in their own language, from individuals who work on the NHS side of the coin. And a really interesting point around vulnerable groups of being able to show where you have worked with vulnerable groups before, but having done your homework of potentially what new vulnerable groups may be in this new or new population type in the organization you're trying to work with, to show how it is that you're going to include them as well as part of this piece of work. But also being cognizant that sometimes showing how you work with and address the impact on vulnerable groups is just showing that you've increased capacity to allow them to get access to something new. So parting thoughts, for those of you who want to listen back to this or share it with colleagues, we will share the recording as well as a summary on our website. But do look out for our final webinar in this series. We are going to have a session chaired by Neela Patel, who's the Chief Executive of MedCity, as well as Henry Potts, who's a professor at UCL. The session will be focused on regulation and evaluation of AI. Are we there yet? So NICE and the HRA will be here to discuss updated evidence frameworks. And you'll also be able to hear from a company who has interacted with NICE through the AI Award, sharing their experiences. So please do sign up for that. We have popped the link in the chat to allow you to sign up for that. So please do look out for it. Thank you all so much for today and enjoy the rest of your Thursday.